Hi, everyone. Welcome to this webinar, specifically dealing with platelet defects that include both Glanzmann's Thrombasthenia and Bernard-Soulier syndrome. My name is Jim Munn, and I'm a nurse coordinator at the University of Michigan's Treatment Center in Ann Arbor, Michigan. These are my disclosures. And I wanted to start off by talking about the whole concept of coagulation, or another word that you may hear called hemostasis. And what it is a pretty nice choreographed dance between the things that you see listed here: procoagulants, which are our factors or our plasma proteins, some natural inhibitors in the body that help control the process from going out of control, and then fibrinolysis, which is the process by which a clot is broken down by enzymes when the clot is no longer needed. And those choreographed dances all occur on the phospholipid surfaces of both endothelial cells and platelets. Specifically, the role of platelets in hemostasis are to start the whole process. When a blood vessel is injured and there is some problems with the opening of the blood vessel and leaking of blood into the vascular space, then we have the need for von Willebrand's to bring platelets to sites of injury. And from there, they form a primary hemostatic plug. During that time, they begin to secrete substances as well that allow for more platelets to come to the sites of injury. It causes the blood vessel to contract or get smaller, so less blood is lost. And it also allows for the coagulation process, those choreographed dances between the plasma proteins or the factors that help make the fibrin clot. And again, this all happens on platelets because they have a great phospholipid membrane, and it allows for the formation of the complexes between the factors in order for the clot to be made. As far as platelets in the blood, there's about 150 to 450,000 in the normal blood draw, and they have a lifespan of about 7 to 10 days. When you think about blood at any one point in time, as far as platelets are concerned, about 2/3 are in your circulation. The other third are being pooled in the spleen because the spleen is necessary to break down platelets that are no longer needed, ones that have come to the end of their lifespan, ones that look damaged, and ones that may have formed a complex with von Willebrand's factor. Platelets themselves are manufactured by megakaryocytes in the bone marrow. Whenever we diagnose a patient with a platelet disorder, we always do the same thing that we do with anybody else. We take a good history, we do a physical, and then we get some laboratory investigations as well. So from a historical assessment related to platelet function, a couple of things that we think about is, first and foremost, what is the age of the individual when the symptoms begin? Because if they're young, it's often an inherited disorder. And if you're older, when you have these diagnosed, it may be because you have an acquired platelet defect. Medications, including those that are prescribed, over-the-counter, and even herbal supplements, can affect the platelets. So we have to watch for those kinds of things, and we ask about those. In fact, when someone comes to clinic, we will ask them of any medications that they started and when did bruising occur in relationship to that new medication. And then of course, we always assess the bleeding history of other family members, because if the parents happen to have symptoms as well, then it's likely to be a dominant disorder. And if they don't have any symptoms, it's likely to be recessive or possibly an X-linked platelet disorder. When we look at genetics risk, we also know that from the standpoint of severe congenital platelet dysfunction, they are actually very rare. They become more common in scenarios where you have close family groups that are intermarrying, or you may have geographically some isolated communities in which, again, the gene is passed because there's fewer people for intermarriage or for marriage to occur, and that will happen. The more common defects with platelets actually are heterozygous in their formation, and so often it's just a 50-50 chance that you could pass that on to your own children. When we look from a physical examination standpoint, we're looking for a few things. Are there any bruises or hematomas on the body? Is there petechiae, the small red dots that occur? Sometimes you'll see them inside the oral cavity on your extremities. Has the liver or the spleen enlarged? Could that be because sometimes the platelets are being, like I said, eliminated through the spleen, and if that's happening at a fast rate, it may cause an enlargement of the spleen. In the more advanced platelet disorders, one where the glycoprotein membrane is affected, then we also can have bleeding that will happen in muscles or joints. And when that happens, if there's been enough bleeding, you can get some muscle atrophy and limited range of motion of the joint that's been affected. From a laboratory evaluation standpoint, initially, people may have been given a bleeding time. That now is pretty archaic, and it's no longer used. And that's because there's some challenges associated with it. It's really technically difficult to do. It's very often not able to be reproduced by even the same technician, and it may not be a good correlation with clinical bleeding when we get the results. We also, from a laboratory evaluation, will look at the actual platelet count and how the platelet looks under the microscope. And it's interesting that most of the platelet function defects actually have normal count and morphology. And lastly, we can look at platelet aggregation and secretion studies as well. There are a number of agonists or stimulators that we call that are used when we do platelet aggregation studies, and they're listed here. This is an example of, for instance, ristocetin, one of those stimulators. And when platelets react at low doses of ristocetin, it's often a concern that this may be something like 2B von Willebrand's disease or a platelet type of disorder, because the disorder for the platelet or the interaction is not on the platelet surface, but it's on the von Willebrand's surface. There are a number of variables that can affect platelet aggregation testing as well. First and foremost, how good was the sample collection? Did it cause any trauma during the time that the blood was drawn? Is it a platelet-rich preparation? We need to have that in order to get a good platelet count. Temperature can affect this. When specimens are drawn, when people have had fried fatty foods, or if for some reason the elevation of their lipids is present, it will cloud the process of testing to be done, because the testing requires some light transmission to occur. And if you're lipemic, when your blood has a lot of fats in it, it can interfere with that light transmission. The interval or the time from when the venipuncture was done, the longer the blood sits, the more likely it's to be destroyed, and it will be difficult for us to get a good platelet function test. The size of the cuvette that's used in the drawing up of the blood, and then of course the rate of stirring, the size and shape of the stir bar. And of course, other things like drugs, which we mentioned before, and even smoking can affect this testing. Another test that we might be able to do is electron microscopy, and that helps us classify some of the disorders. It's useful because it actually can look at the cytoskeleton of the platelets. The organelles that are in there, the most common that you may hear about are alpha and dense granules. And also, if there's any membrane defects, we can pick that up with electron microscopy as well. From a platelet function standpoint, this is a slide of actually what you should see in a normal peripheral blood smear. You see a lot of red blood cells, and then the arrows are pointing to platelets. And you'll notice that those are usually much smaller than red blood cells are. And I think the one here on the left indicates one that maybe has already been stimulated and is starting to go through the process of activation. That whole process, transforming inactivated platelets into a well-formed plug, involves 3 steps. The first is initiation, which is when the von Willebrand brings the platelet to the site of injury, and then that adheres to the collagen that's exposed because of the broken blood vessel. Extension, which is the process of when the cells start to eliminate their contents. And lastly, cohesion, where the platelets will interact with each other. And the defects that we're dealing with today specifically have problems with initiation, that will be the Bernard-Soulier syndrome, and then the cohesion, which is the Glanzmann's thrombasthenia. But we'll look at that in a minute. So, as far as the initiation disorders are concerned, we talked about one earlier, and that was the platelet type von Willebrand's disease. Remember, this is a defect on the von Willebrand's molecule, not the platelet. So I just wanted to give you some information about that so that you knew the difference between the two. Bernard-Soulier syndrome was first described back in 1948, and it's an autosomal recessive disorder, which means both parents have to give the gene to the child in order for the Bernard-Soulier syndrome to be expressed. It results from an absence of a glycoprotein that's called 1B95 receptor. And in this scenario, like you can see on the right, if you remember, the platelets are normally small, but here they're quite large. So they're called macrothrombocytopenia because they're big in size, but small in number. And the process associated with Bernard-Soulier syndrome is that it's a loss of function of the platelet. The cohesion defect, on the other hand, is Glanzmann's thrombasthenia. What happens is that the glycoprotein membrane, which is now called integrin alpha 2b beta 3, formerly known as glycoprotein 2b3a, that receptor is missing. And we now have identified 3 different subtypes for Glanzmann's. It's type 1, which is the complete absence of the glycoprotein. Type 2, where there's about 10 to 20% of antigen expression in the blood. And type 3, where the amount that's present is normal, but it's an abnormal function. This defect was first described way back in 1918 by Edward Glanzmann. He was a Swiss pediatrician who noticed lots of bleeding and bruising in Swiss children. And what he did was he called this thrombasthenia, which is the French term for weak platelets. Again, this is another autosomal recessive disorder. It's found on chromosome 17. So we can look for genetic mutations for this as well. And then aggregations that are done show no response to any of the agonists except ristocetin, because ristocetin is the agonist that stimulates von Willebrand's, bringing the platelets to the site of injury. In Bernard-Soulier syndrome, that's exactly what we see, is that patients don't respond to ristocetin like they should, but they do respond to the other agonists. Here's another big pictorial representation of just this whole scenario. So again, look right here. This is Bernard-Soulier again, where the von Willebrand's helps the platelet attach to the endothelium, the subendothelium that's been exposed because of the breakdown of the blood vessel. And over here is the platelet-platelet interaction that is Glanzmann's thrombasthenia. Again, the glycoprotein 2b3a leakage. What happens during the process of the whole blood clot, and I'm hoping that you can take a quick look at me, is that platelets start off looking like this in the blood, and they circulate, but when they need to do their function at some point during extension, what will happen is the platelet actually turns itself inside out so that it can form this wonderful surface where all the different coagulation interactions occur. And you can see that this is a much larger surface area so that those actions can happen, as opposed to this. And when the extension occurs, when this happens, it's irreversible. So the platelets will not change back to a small little circle. That's when they will get sucked up by the spleen and taken out of circulation. With respect to treatment for patients with especially any kind of platelet disorders, we spend a lot of time on some education for the patient and the family. We want to make sure that people understand that the most common type of bleeding is usually mucocutaneous, So it's nose bleeds, mouth bleeds, GI bleeds for women, menstrual cycle. However, we can have some severe hemorrhage, especially with trauma, with surgery. Sometimes the GI tract gives us a lot of problems. And we may have some postpartum hemorrhage in women with platelet function defects as well. We like to tell patients to avoid any medications that have aspirin in them and also non-steroidal anti-inflammatories like ibuprofen or Aleve, because those will also affect platelets. So unfortunately, we don't give an exhaustive list because that keeps changing all the time. What we generally tell patients is to ask a pharmacist before they go to buy any over-the-counter product to make sure that it doesn't affect platelets. We also make sure that all of our patients are given a medic alert, because you want that so that people know when you're in a car accident that there's a potential for bleeding because of your platelet defect. And also that we recommend regular immunizations for hepatitis A and B. That's happening now in infancy, so those are occurring all the time. If you're an adult and have not had those done, we would recommend that you get them. And then, of course, we give information on when it's most beneficial to call the HTC with concerns. Treatment in platelet disorders, again, can be anything related to antifibrinolytic agents. Remember, fibrinolysis is the enzymes that eat up the clot. Well, we have products that have been used. Aminocaproic acid and tranexamic acid are two examples of that, and they are used for mucous membrane bleeding for the most part. One thing you need to remember about the antifibrinolytic agents is that you never use them when you have blood in your urine present, because it can cause problems with clotting in the kidneys. We also can use desmopressin acetate. We have been able to use it in storage pool disorders. Usually there is some response, but not always. And it also increases the level of the von Willebrand's factor, which is helpful to bring those platelets again to the site of injury. The actual effect on platelet function still remains undefined with respect to the desmopressin or the DDAVP. Red blood cell transfusions occur in patients who are anemic. We do iron replacement therapy for people who have had chronic blood loss in order to bring their iron stores back to where we need them to be. We can use recombinant factor 7A. It has a license for Glanzmann's thrombasthenia. Platelet transfusions are done. We'll talk a little bit about that. And then there is now some gene therapy that's going on in platelets with patients with platelet disorders, especially the Glanzmann's patients. As far as platelet transfusions are concerned, we use those often for only life or limb-threatening bleeding. And we often will order an apheresis unit, which is about 5 to 6 pooled blood bank units at the same time. We try to minimize multiple donor exposure because as that occurs, every time you get a platelet transfusion, you can start to get a sensitization to other people's platelets. And once you develop antibodies against those platelets, you start to get a refractory state. We also have leukopoor or leukocyte depleted platelets, and that's now very common across blood banks in the US. And this is in preparation to also minimize that long-term sensitization that can happen to the HLA class 1 proteins that are expressed on the surfaces of platelets. And we also like to avoid exposure to platelets in any disorders with an absence of a membrane glycoprotein. So remember, Glanzmann's and Bernard-Soulier are those two platelet defects that have that glycoprotein membrane problem. Remember Glanzmann's, it's the alpha 2b beta 3, and for Bernard-Soulier, it's the glycoprotein glycoprotein 159. And the reason that we really try to minimize them in these patients is because, again, the formation of the iso or allo antibodies is very high. And of course, you can become refractory to transfusions in the future. When we think about the two disorders, Glanzmann's and Bernard-Soulier, when you go forward and have a major surgery, depending on your treatment center, they may use recombinant 7A. We will use the HLA matched platelets, especially if there's a risk of bleeding with recombinant factor 7A. We also may use antifibrinolytic therapy depending on the type of surgery that's being done, if it involves mucous membranes, for instance. For minor surgeries, often we can get by with recombinant factor 7A, about 90 micrograms per kilogram, immediately prior to a procedure, and then it's given, depending on the patient and the surgery, potentially every 2 to 12 hours, with increasing intervals as things are going well from a hemostasis control standpoint. The initial dose might be higher in children because they require a little bit more. They have a faster metabolism with products. We may also use HLA platelets, antifibrinolytics, and for dental procedures, often all we need is recombinant 7A or antifibrinolytics alone. And then we often can tell the dentist to put in some topical hemostatic agents as well, because that will help control site bleeding right in the socket itself. I just wanted to thank everyone for being here for today's session. And at this point, please make sure you do your evaluation, and I'm open for any questions that you might have. Thanks.